Indian scenario.
So very good morning. Before going to my subject, one or two announcement because today I was not there. I request all of you to become the latest member of IIP Neurology chapter. As such, the membership strength of our chapter is not very high. So please become a member of Neurology chapter. You have to pay, for life membership you have to pay only 1,000 rupees. You can contact either me or Dr. Anup Verma. And the application form is available along the last page of our journal, or you can download it from our website also, www.iipneurologyindia.com. And I also invite you, all of you, to the Neurology Chapter Symposia to be held on 18th of January, along with the National IIP Conference to be held at Kolkata. On behalf of the IIP Neurology Chapter, I would like to congratulate and thank the organizing committee, Professor Kumaresan, Dr. Vishwanathan, Dr. Jayaguma, and of course Dr. Pandian and their team. And to my topic, I am afraid that I am the first pediatrician to talk about a topic in this session. And next 20 to 25 minutes, I'll talk from a pediatrician's viewpoint of pediatrician perspective, next 20 to 25 minutes. So, this is my scheme of presentation. Introduction and definition, our experience as a government medical college Thrissur, and the difference between pediatric and adult stroke, etiology with some clinical scenarios, investigation and treatment, and lastly conclusion. So as according to WHO, it's a clinical symptom of rapidly developing focal, a global distance of brain function, either focal or global, lasting more than 24 hours or longer, or leading to death with no cause other than vascular origin. It is mainly meant for the adult. As such, there should be some change regarding pediatrician. So some pediatric knowledge questioned the terminology, the definition. So a practical definition is that acute onset of focal neurological deficit in a child is stroke until otherwise proven. So it is our study, socio-demographic and clinical profile of acute stroke syndrome in children. Study conducted in Government Medical College Thrissur, and to study the demographic and clinical profile of all cases of acute stroke, and also to identify the parameters associated with the better outcome. And the period of study was September 2009 to February 2011, 18-month study. And all cases of stroke diagnosed clinically and age group between more than one month to 12 years, and exclusion criteria, ADAM, congenital hemiplegia, and less than 1 month. And the outcome we are measured in terms of residual neurological sequelae over 1 year follow-up, motor weakness, cranial involvement, and seizure disorder. So total number of, during this 1.5 years, we have a case of 32 cases, and of course males outnumber the females, and the age varies from, but mean age is 6 years. And also we have 24%, 76% of cases are due to ischemic stroke, whereas 16% hemorrhagic, and 3 cases due to venous sinus thrombosis. And we could find out only 44%, we could find out the exact etiology. It is comparable to other studies also. Infection-associated vasculitis in 12%, and heart disease in 4 cases, and hemorrhagic disease 2 cases are there. Nephrotic syndrome 1 case, and 1 case of protein C deficiency and arteriovenous malformation. So they are present, commonest presentation as motor weakness, and hemiplegia is main presentation with altered sensorium, seizure in 44%, and the cranial palsy, of course, the 7 is very common. And we investigated according to the, because the etiology is different, very different, unlike in adult, it is totally different. So we had a wide variation. Hemoglobin values from 5 to 12.8%, and the anemia, important fact 6. We don't know whether it is directly, the iron deficiency anemia is found to be more associated with the stroke predisposition. A mandatory was positive 1, and abnormal PT-APTT in 2 patients, protein C and protein S deficiency in 1, and HIV in 1 patient. We can't find out any case with sickle cell anemia. We had sickle cell anemia cases, but there is no associated stroke, and no case of homocystinuria or any collagen vascular disease or VDL was negative in all cases. And during presentation, around 72% with combined in stable condition, vitals are stable. And due to it was 22% they are unstable. And EEG was not predictive. We got 10 total seizure cases was around 10 patients out of 32, but neither seizure nor EEG predictive of the final outcome. And unlike in adult, we see more cases of cerebral cortex. Unlike large vessel, small vessel involvement, we see only 6 patients, cerebellum 1. We see large vessel involvement up to 20%, 20 cases. And normal 5. I am very sorry to say that 5 means some of the cases we are not in MRI. Based on CT scan, it was normal. And follow-up, comparatively very good recovery in 60% of cases. A very good outcome in thrombotic infarcts means only 5 had residual weakness at the end of 1 year out of 21 cases. And we had recurrent stroke in 4 out of 32 cases. Myomyelitis disease 2 cases there, hemophilia, and protein CS deficiency, they had recurrent attack of stroke. And mortalities in hemophilia, 1 patient of hemophilia has died, and 1 child with cardiomyopathy died of cardiac failure rather than stroke. So, when dealing with the stroke, we have to always keep in mind the stroke mimics also. Why the differentiation is difficult? Because as such, the exact figure, in Indian scenario, it is not very clear what's the incidence of stroke. In Western countries, there are so many figures are there. Incidence of stroke is 13 to 33 in India. It's not age matched. It includes both children and adult. Because many times the differentiation is difficult because subtle neurological presentation, and also underdiagnosis is a problem. And of course, in countries like India, delay in diagnosis also is there. And many conditions mimic stroke. For example, postictal weakness, pseudoparalysis, hemiplegic migraine, and alternative hemiplegia, ADAM. And also tumors, especially when there is acute bleeding, and a reversal posterior leukoencephalopathy syndrome. So all these things you have to keep in mind when dealing with a child with weakness. What are the difference between adult and pediatric stroke? Etiology is mainly primary vascular in adult, whereas in 30 to 50%, it is so many associated with so many other diseases we are going to see. And as I already discussed, 50% stroke in children is ischemic and hemorrhagic, 50% each almost, whereas in adult it is mainly ischemic stroke. The mode of presentation is uniform in adult because uniform etiology, whereas different mode of presentation we are going to see. And imaging is main investigation, whereas we have to investigate so many conditions, primary conditions. Treatment options are limited but well established in adult. And we got very wide options of treatment because of the different etiology, and we are following the adult model of treatment. Poor outcome is there for adult. Actually, as in our study, it's a comparatively very excellent outcome. So how will you classify stroke? There are main 2 types. One is ischemic and hemorrhagic. It may be arterial ischemic stroke, or it may be sinovenous thrombosis. It's a long list of cause for the stroke in children. One important one is cardioembolism. Around 1/3 to 50%, 30 to 50% is a cardiac embolism. It may be congenital heart disease or acute heart disease in the form of rheumatic fever, cardiomyopathy, arrhythmia, prosthetic valve. Nowadays, due to more and more intervention cardiology, we are seeing more cases of following surgical also. It's a case of non-case of cardiomyopathy, admit with the altered sensorium and weakness of the left side of the body, exercise huge cardiomegaly, and the echo prove it is a poor contractibility with the thrombus in the left ventricle. You can see diffusion imaging, you can see the acute infarct. Again, ACD also you can see the same findings. This child was expired due to cardiac failure. And a lot of hematological conditions associated with, especially in pediatric age group, hemoglobinopathies in the form of sickle cell anemia, thalassemia, iron deficiency anemia, ITP, purpura, hemophilia, vitamin K deficiency, and protein CS, and nephrotic syndrome also one cause. We are presenting a case of a 45 days old child with swelling and bleeding from the left side following a DPT injection, around 45 days, first dose of following. It is not more than a medical problem, it is a social problem in my area, because following injection, child developed bleeding, convulsion, and a repeated focal seizure, and no fever, no feeding difficulty. You can see a large hematoma on the left side of the thigh with the seizure. All investigations are normal except PT and APT. They can see this hematoma with the midline shift and effacement of the ventricle. So it is a case of hemorrhagic disease of the newborn. We treated with the supportive measures, anti-epileptic treatment, and vitamin K. Child is fully improved without any neurological sequelae. Child is a wonderful recovery. It's another case of a non-case of hemophilia from a rural area. He is not taking this factor VIII regularly, very poor family, and he had recurrent attacks of stroke before that one. He came in a very unconscious stage this time with a large hematoma with a midline shift, and he also died. It's an interesting story from a pediatrician point of view. Admitted with the gum bleeding, a 18-month-old female child. History of delayed umbilical fall. All routine and coagulation profile was normal. Admitted deep coma state following a minor trauma. So minor trauma, stroke following minor trauma. Yesterday, Dr. Jayakumar discussed some of these case scenarios. So it is a case like that. You can see large subdural hematoma. The child was very pale due to bleeding. Actually, it is a case of factor 13 deficiency. All coagulation profile were normal. And we investigated, sent the blood sample to CMC Vellore, and they showed that it's a factor 13 deficiency. Again, this child also made a complete recovery. Vasculitis and vasculopathy is another important cause, especially the CNS infection is not very uncommon in pediatric age group. So it may infectious, immune-mediated, AV malformation, hypertensive encephalopathy, and moyamoya disease. So, an interesting case of father and mother died of tuberculosis following HIV infection, looked after by the grandmother. A care of complaining of fever, poor appetite, lethargy of 2 weeks duration, weakness of the right side of the body. All routine measures are normal, Mando test negative, chest X-ray was normal, and HIV positive. You can see a large infarction mainly involving the left side of the brain. Again, it is different made imaging and ACT showing same findings. So actually, it is a case of moyamoya disease. Dr. Jayakumar yesterday discussed in detail, but I want to highlight HIV and moyamoya disease. Only very few case reports are there in the literature. I think there's no article from India. Another child with a recurrent stroke. This is our second case. Weakness of first on the right side 4 months ago, followed by left side also. It is a classic case of a Down syndrome. And showing pyramidal tract involved both left and right side with varying power because of the 2 months duration, 4 months duration, so some varying power. You can see. So old coronary artery region is old infarct, and also cortical atrophy, and also here you can see that. And a diffusion image showing that the features of acute infarct in the caudate nuclear area and also the parietal lobe, peritrigonal area, and also MRA showed acute obstruction of the supraclinoid part of internal carotid artery with the collaterals. You can see the classical MRI angiography showing that both the middle cerebral artery is not visible, and Puffer's classical finding of Puffer smoke appearance with the collaterals. So it is a case of moyamoya syndrome. So when we call syndrome, it is associated with a syndrome like condition like Down syndrome, neurofibromatosis, sickle cell disease, and moyamoya disease when patient with the non-associated risk factors. And the symptoms are made due to 2 factors. One is occlusion of the vessel, as in this case, it may lead to stroke or mini stroke-like condition, whereas sometimes it may be due to hemorrhage from a fragile collaterals. But such findings are more common in adult. In pediatric, moyamoya disease usually classical presentation is ischemic stroke. And the treatment options include warfarin, calcium channel blocker for the headache, surgical. Actually, our Down syndrome patient underwent surgical, superficial temporal arteries anastomosed, and child is improved. They operated from Sri Chitra Institute, Trivandrum. And I am not going to detail about a new entity. It's not in pediatric stroke genetic basis. Article 5, Vijaya Ganeshan. So many more and more new findings are coming up. And how to evaluate diagnosis of stroke by history? You have to ask onset, progression of neurological deficit, and a history of trauma, even minor trauma, seizure, fever, headache, and even ear infection, and focal neurological deficit, aphasia, altered sensorium, and symptom may be diffuse and following a minor trauma. Say article from AFMC, Pune, ischemic stroke following mild head injury. So many case reports regarding basal ganglia involvement with stroke. And a clinical feature also depends upon the territory of the artery involved, whether it is internal carotid, middle carotid artery. And of course, a wide variety of condition we already discussed depends upon the primary condition. You have to assess vital signs, Glasgow Coma scale, look for the fever, headache, and the meningeal signs. Anemia, I already mentioned about iron deficiency anemia, sickle cell anemia. A trauma may be a reason for hemorrhage, dissection, minor head trauma as a cause or cofactor. Look for bleeding manifestation organomegaly. And hemangioma, you get Stuber syndrome, angiokeratoma in Fabry's disease, and dysmorphism, as in our case of Down syndrome, or Marfan or homocystinuria, dislocated lens, Marfan, homocystinuria, a fundus examination will give some clue. Short stature ataxia, adult delay, melas. And the vasculitis, you may have different types of vasculitis may present with rash, hypertension, renal problem, and the cardiac, of course, we discuss. It is one of our case with the weakness of one side of the body with the Stage-Weber syndrome. And investigation, a lot of investigation, but you have to use judiciously because all investigation not indicated in all cases. So you have to stroke panel, prothrombotic factors, protein CS, anticardiolipin antibodies, HIV, lactate pyruvate level according to the clinical scenario. And imaging is very important as early as possible. And we are very lucky, we can do neurosonography in infants, we get a rough idea. And CT scan is important to exclude hemorrhage, but the problem is that it can be normal in initial 12 hours of scan. MRI including diffusion weight imaging is the procedure of choice, I already shown. If MRI suggests ischemic stroke, then you have to do for MRI angiography or cervical and rectal vessels. The emergency MRI is important because you have to exclude hemorrhage, define the extent and trajectory of the infarct, whether it is progressing or not, and angiogram to define the vascular anatomy, and T1 weight image to especially to exclude the cervical or neck carotid dissection, MRI to exclude sinovenous thrombosis, and diffusion imaging to differentiate acute from chronic infection. Here you can see almost flyer image almost normal. Retrospectively, if you are looking, you can see some changes here. Otherwise, it is normal. Diffusion weight imaging and the ADs is showing the features of the acute infarction. And again, you can differentiate whether it's a large infarct, small infarct. And the digital subtraction angiography is important in hemorrhagic stroke to rule out AV malformation and aneurysm. Treatment is different. Acute ischemic stroke angiography is important when dissection is strongly suspected, but MR is negative. So it is a case of AV malformation. You can see large MR is showing large AV malformation. So next step is the management. As a pediatrician, we have to stress on supportive general measures and supportive measures. Our aim is neuroprotective strategy at earliest, rapid diagnosis and stabilization with the airway, breathing, circulation, and euglycemia, dextrose. And you have to minimize size of the infarction by controlling proper control of fever, seizures. The role of anti-epileptic drug is questioned, prophylactic role. The blood pressure should not be reduced suddenly, and you have to keep in the upper limit of normal. And hypoglycemia. Euglycemia is very important because hypoglycemia is going to be more adverse reaction. So the concept of brain attack should be there. Just like a heart attack. People are more about heart attack and all this management. Emergency management, CPR, everything is very familiar. Should be have awareness about the brain attack management. So you have to identify early evidence rise in ICT, optimize of intravascular volume, stroke volume, and perfusion pressure, mechanical ventilation in severe case, and a neurosurgical consultation for hematoma, hydrocephalus, and intractable intracranial tension. Specific treatment include aspirin, anticoagulants, thrombolysis, specific treatment for primary disease. So whether it is antithrombotic or anticoagulant. So if it is rapid flow stenosis, ischemic stroke, it may be to platelet activation, antiplatelet drug like aspirin may be the choice. A slow flow stasis, it is a hypercoagulable stage, prothrombotic stage, coagular system activation, you have to give anticoagulant. So anticoagulants in stroke, the class 1 recommendation is that anticoagulation with the low molecular weight heparin is useful for long-term anticoagulation in children with a substantial risk of arterial dissection, venous sinus thrombosis, recurrent cardiac embolism, and selected hypercoagulable states. And heparin should be followed by warfarin, 0.2 mg per kg, and you have to titrate the dose according to the need. And the administration of low molecular weight heparin and unfractionalized heparin may be considered in children up to 1 week after an ischemic stroke, pending further evaluation to determine the stroke etiology. So, you can see unfractionalized heparin, 18 to 22 units per kg. Some people not recommending the loading dose in stroke. Warfarin also, 1.12, And you can give weeks to months warfarin and low molecular weight heparin 0.1 to 1.5 milligram per kg, easy to monitor. And aspirin, low dose aspirin 3 to 5 milligram per kg per day. And as I already mentioned, it is recommended in ischemic stroke. It is not advisable in sickle cell disease, cerebral venous thrombosis, hypercoagulability, or Moya-Moya syndrome. TPA in children, it is not recommended as a treatment option in children at present. Safety is not well studied, dosage not exactly not known. And there is a diagnosis of stroke many times after a long time. So the time may be elapsed. And poor emergency access to CT scan, MRI, and also TPA is very common in our country. So it is not advisable at present. And manage stroke and sickle cell disease, extend transfusion to reduce hemoglobin, sickle cell hemoglobin to less than 20%, and you have to increase the level of hemoglobin also more than 10%. And the hydroxyurea and the bone marrow transplantation you can consider later. The iron deficiency anemia, there is a strong association. There is increased thrombopoietin production in iron deficiency anemia. RBC are not deformable, such as for hypercoagulability is there, and there is venous stasis due to arterial dilatation. All these predisposed to stroke in iron deficiency anemia. The child with the virus associated infection, the child who got anemia, iron deficiency anemia, they are more prone to develop stroke rather than control. Heart disease and stroke, we already discussed. Treatment of congestive cardiac failure, correction of congenital heart disease, and the resection of arterial myxoma, and of course, low molecular weight heparin, warfarin for cardioembolic stroke. And sometimes there may be unrecognized patent foramen. Sometimes you have to correct that one also. So, acute ischemic stroke confirmed by CT scan and MRI, you have to give 5 to 7 days of low molecular weight heparin. If it is idiopathic stroke, arterial stroke, cerebral arteriopathy, or intracranial dissection vasculitis, aspirin. But if it is a cervical dissection, cardioembolic stroke, or hypercoagulable state, prothrombotic state, stroke while on aspirin, rest in the case of aspirin, you have to give warfarin. Of course, we have to treat specific disease, but we can do much more than the primary treatment. Treatment of iron deficiency anemia, regular transfusion of factor VIII, long-term steroid in ITP, a trial of pitoxin, and homocystinuria. A monitoring of BPs annually to screen hypertension, especially in predisposed children. Immunosuppressant anticoagulant for patients with the antiphospholipid syndrome. Children with the prothrombotic tendency should be referred to hematologist. And hemorrhagic stroke, you have to replace the coagulation factors in factor deficiencies. We have 2 children. One is a factor 8 deficiency, another factor 13 deficiency. Platelet transfusion, IVIG, steroid in case of ITP. And in arteriovenous malformation aneurysm, you have to do surgical management. And another important tool is cavernous cerebral venous sinus thrombosis. Because children are more predictable, got diarrhea, dehydration shock, nephrotic syndrome is very common, post-thrombotic state, and what is media. All this lead to cerebral venous thrombosis. It's an 8-year-old girl with the steroid-dependent in the case of nephrotic syndrome, person with headache, vomiting, altered sensorium. Can you see larger sinus thrombosis here? So, nephrotic syndrome is one predisposing condition, one common condition in pediatric age group. Of course, many times we are forgetting about the follow-up and other supportive treatment. Rehabilitation very important. Physiotherapy. Many patients came after a long time with the crippled condition. Nutritional care of eye and skin, bladder and bowel care, management of learning problems, and speech therapy. Now, of course, family support is very important. So, to take a home message, awareness and incidence of stroke is increased. Nowadays, more and more awareness about the stroke conditions there. So, more and more cases are reported. And due to facility for investigation, etiology is known in more number of cases. Previously, majority of them are idiopathic, but nowadays with the more and more investigation, many of them come in different classic condition. And MRI, in emergency basis, the investigation of choice. Many times it is not available, but this investigation of choice. And wide treatment options are available, unlike in adult, because of varieties of condition, cardiac condition, hematologic condition, vasculitis. So wide treatment options are available. And outcome is reasonably good in children, as shown in our study. Thank you for the patient hearing.